Assalamualaikum warahmatullahi wabarakatuh and a good day to everyone. I am Dr. Nazira Fatima binti Kalikul Jaman from PKD Sepang. Today, I will be presenting on wound management in primary care part 1. This is the outline of my presentation. In the beginning of the presentation, I will be discussing the basic wound principles, which are the definition, classification of wound and stages of wound healing. Then, I will go through the principles of wound assessment and learn how to document wound based on our assessment. Skin is the outer covering of the body and thus it provides protection. It is the largest organ of the body in terms of weight and surface areas. It consists of different tissues that are joined to perform several essential functions. Skin thickness ranges from 0.5 mm to 4 mm depending on location. The functions of skin are to regulate body temperature, act as a protective barrier against mechanical, thermal, physical injury or any hazardous substances. It also acts as a sensory organ to pain, touch and temperature. Skin also serves as an immune function and blood reservoir. Structurally, the skin consists of three principal layers which are epidermis, dermis and subcutaneous layer. The epidermis is the outermost thinner layer and is composed of epithelium. The dermis is the thicker layer and consists of connective tissues. It is followed by subcutaneous layer which is the deepest, which consists of hypodermis and adipose layer. Now let's move on to the definition. A wound is any type of damage or breakage on the surface of the skin. The wounds can be due to accidents like burns, paper cuts, skin tears, or any surgical wound. It is visible result of an individual self-death or damages. It may or may not result in a loss of skin integrity, whereby physiological function of the tissue is impaired. On the other hand, an ulcer is an open wound that develops on the skin as a result of an injury, poor circulation, or due to pressure effect. It is usually as a result of an underlying or any internal etiology. A wound can be divided into superficial and deep wound. The superficial wound causing damage to the epithelium only, and it can heal by epithelial regeneration and may have little scar formation. Whereas in deeper wound, for example, incisional and excisional wounds that damage the dermis, it will heal through the formation of a collagen scar. It is important to remember that blood supply is predominantly found in the dermis and it is essential in wound healing. Now let's learn about wound classification. There is in fact no standard classification for wound. The classification used in this presentation is based on the timing, etiology of the wound and the skin layers involved. The first classification is based on the timing, whether it's an acute wound or chronic wound. Acute wounds are caused by sudden disruption of skin integrity, usually due to trauma or surgery, whereas chronic wound is the wound that fails to proceed through an orderly and timely process to produce anatomic and functional integrity. A non-healing wound is any wound that has no signs of healing process within 2 to 4 weeks after appropriate intervention. It is interesting to know that there is a new terminology now which is called hard to heal wound. It is defined as a wound that fails to heal with standard therapy in an orderly and timely manner, and it may be used to replace the term chronic wound. Generally, wound heals within 4 to 6 weeks. Chronic wounds are those that fail to heal within this time limit. Many factors can lead to impaired healing process. This term hard to heal wound applies to both acute and chronic wounds. Next, the wound is classified based on their etiology. Each type of wound has different etiology. Not all wounds are clear-cut. They may be multifactorial. Many wounds do have mixed etiology. They may be both venous and arterial insufficiency, or they may be due to diabetes and pressure effect. Treatment may be very different. To treat the wound, we need to identify its correct etiology and to give treatment accordingly for better wound healing. Wound may also be classified according to the number of skin layers involved. In superficial wound, it involves only the epidermis, while partial thickness wound involves the epidermis and the dermis layer. For full thickness wound, it involves the epidermis, dermis, fat, fascia and exposed bone. Wound healing is the process that skin goes through as it repairs damage from wounds. There are three main types of wound healing, known as primary, secondary and tertiary wound healing. Healing by primary intention is where the two opposed surfaces of a clean incised wound are held together. Healing takes place from the internal layers outwards. Any surgical wound will heal by primary intention. Secondary wound healing occurs when a wound that cannot be stitched due to a large amount of tissue loss. This may be more common for wounds that have a rounder edge, cover uneven surfaces, or for wounds on surfaces of the body where movements make stitches or other closure methods impossible. Secondary wound healing relies on the body's own healing mechanism. This process takes longer, which may be due to increased wound size, the risk of infection, contamination, and other factors such as the use of certain medications like steroid. During secondary healing, granulation tissue formation and epithelialization over this tissue takes place. These types of wounds are more susceptible for infection and poor healing. Tertiary wound healing or healing by delayed primary closure occurs when there is a need to delay the wound closing process. In tertiary intention healing, there is a need for the wound to be open for a period of time before it can be sutured. Example can be a wound left open to allow drainage and later it is closed, or a wound that is left to heal by secondary intention. Every wound goes through various stages of healing depending on the type of wound and its severity. Understanding these categories as well as the steps of the wound healing process can help people understand how best to care for a wound. The stages of wound healing proceed in an organized way and follow four processes, which are hemostasis, inflammation, proliferation, and maturation phase. Wound healing process starts at the moment of injury where the clotting cascade is initiated. The inflammatory phase, which is characterized by swelling, redness, pain and heat, will occur at the same time. It also involves infiltration of wounds with neutrophils and macrophages to prevent infection. Then proliferative phase will commence where fibroblast migration, reconstitution of dermis, formation of a new blood vessels and re-epithelialization all come together to form healthy granulation tissue and causing the wound to contract. Later, tissue remodeling or maturation takes place where type 3 collagen remodeled to type 1 collagen and the wound fully closes. In managing wound care, our goals are according to this wound bed preparation care cycle. It starts with the patient, identify the wound etiology, performing time assessment, treat and evaluate time intervention. If the wound heals, aim to prevent future wounds, and if it isn't, review back the process as mentioned. Wound assessment is an essential skill for providing wound care. Wound assessment can be divided into a general assessment and a local assessment. For a general wound assessment, we need to identify and eliminate any underlying causes or contributing factors which may delay the wound healing process. The following are identified as some of the main causes for delay in wound healing. There is an acronym called HEIDI, HEIDI, which stands for history taking, examination, investigation, diagnosis, and implementation. We can use this acronym as a guide during our assessment in daily practice. For history taking, we need to ask about patients' past medical history, past surgical history, need to know about their social support, what medication they are taking, and it is also important to know is there any history of previous hospital admission. Then we have to examine the patient systematically and then assess the pain by following PQRST pain assessment method. Then we can do a local wound assessment. It is important also that for diabetic patient, don't forget to screen for diabetic peripheral neuropathy and peripheral arterial diseases. Now we move on to investigation. For wound assessment, investigation is used to aid our diagnosis. The following tests may be useful to identify factors that can slow wound healing. FVC count to assess for leukocytosis, anemia or thrombocytopenia. Analysis of the patient's renal profile to look for renal insufficiency and electrolyte abnormalities, as we know that high urea impairs wound healing. In some patients, we do liver function tests to determine their serum protein and albumin level to assess the patient's nutritional status, as we know that protein loss also delays wound healing. In general, radiological imaging does not play a major role in therapy of the uncomplicated wound. However, wounds that fail to heal as expected can be further investigated with imaging. Therefore, X-ray and ultrasound may be helpful. In certain situations, tissue samples or cultures may be needed as well. This is more relevant in hospital setting. Then, based on our assessment, we must diagnose what type of wound that the patient has, either venous or arterial or any traumatic wound. In diabetic foot ulcer, Texas classification is used, while in pressure ulcer, it is described by its stages of ulcer. After we have gathered all the required information, we can start to plan on how to manage the wound to optimize the underlying diseases and to correct its etiology. All wounds have the potential to cause pain, and the nature of the pain varies with the type of wound. Many factors may exacerbate pain, including infection and dressing change technique. PQRST mnemonic is a valuable tool for pain assessment. It can help us devise an effective pain management and start much needed treatment immediately. PQRST stands for P, provoking factors. What brings the pain on and what makes it better or worse. Q stands for quality. Lets the patient describe the pain. Either it is sharp, dull, stabbing or burning in nature. R stands for radiation. Where's the pain? Does it spread anywhere else? S for severity. How severe is the pain? To assess severity, we can use pain scale 0 to 10 or we can use Wong-Beck Faces pain scale to assist us. T stands for time. We can ask the patient what time the pain started and how long does it last. It is important to assess the pain properly because inadequately managed pain can lead to adverse physical and psychological patient outcomes. Now let us move on to local wound assessment. It is an ongoing process and should include a review of the wound history and proper assessment of the physical wound characteristic. It includes its location, size, base, depth, and presence of pain and the condition of the wound bed. The size, length, width, and depth is important to be measured and documented so that the progress of the wound can be measured over time. The TIME framework is a global wound care framework used to implement appropriate care plans and promote wound healing. The TIME framework can be used to apply wound bed preparation to practice. The correct implementation of TIME depends on patient and wound assessment. TIME is not a sequential process. Every wound is different. Simultaneous attention to one or more of the components may be required. TIME is used to assist clinicians in standardizing the wound assessment and preparation of the wound bed for treatment. Local wound assessment includes assessment of wound size, surrounding tissues, and time. Time will be elaborated further in next slide. For wound size assessment, we need to measure the wound surface, which is the depth, width, and the length of the wound. The size of the wound should be assessed at first presentation and regularly thereafter. Then we need to assess the surrounding skin. Look for any signs of infection, ischemia, maceration, or for any crepitals. Now we move on to TIME. TIME is a valuable acronym or clinical decision tool to provide systematic assessment and documentation of wound. It consists of 4 main components of wound bed preparation. T stands for tissue management, I stands for control of infection and inflammation, M stands for moisture imbalance, while E stands for advancement of epithelial age of the wound. T is to describe tissue viability. Tissue viability can be described as non-viable, which has slough, necrotic tissue, and a viable, which has a LT granulation tissue or epithelialization. T also used to describe color system, tendon or bone exposed, overgranulation tissue, and tunneling. Let us describe and do local wound assessment based on this picture. This wound is in the sacral region, measuring 12 times 8 times 1 centimeter. This wound has moderate purulent exudate. The wound edges are undermining. We can identify that there is a several wound color in this picture, which will be elaborated further in the next slide. Description in green boxes represent time as we discussed before. Now let us learn about the color model. Each color represents different tissues description. Epithelial tissue appears pink or pearly white and wrinkles when touched. Occurs in the final stage of healing when the wound is covered by healthy epithelium. Granulating tissue appears red and moist. Occurs when healthy tissue is formed in the remodeling phase and it is well vascularized and bleeds easily. While slough tissue appears yellow, brown or grey. Slough is devitalized tissue made of dead cells or debris. Necrotic tissue appears hard, dry and black. Necrotic tissue is dead tissue that prevents wound healing. While hypergranulating tissue appears red, uneven or granular. Occurs in the proliferative phase when the tissue is overgrown. The picture on your left shows example of slough tissue, while the picture on your right side shows necrotic tissue with slough. Next is an example of wound with exposed tendon on your left and wound with epithelialization on your right. The image in the next slide shows example of wound with overgranulation and tunneling. Overgranulation is characterized by dark discoloration of the wound with raised or swollen tissue. It bleeds easily and tends to produce higher levels of exudate, inhibiting epithelialization and increasing the risk of infection. Hypergranulation can inhibit wound closure by creating a barrier to the epithelial cells migrating across the wound surface, and it can increase the risk of scar formation by forcing wound edges to further apart. While a tunneling wound is known as a sinus tract, is a type of chronic wound characterized by a narrow channel or tract extending from the wound's surface into deeper tissue. This channel or tunnel can be shallow or deep and may create pockets within the wound. Tunneling wounds are commonly found in pressure ulcers, diabetic foot ulcers, surgical wounds, and wounds resulting from infection. Now we move on to I, which describes infection. This image showing bacterial continuum model. Infection started with contamination followed by colonization. At this stage, no antimicrobial required, but need to be vigilant on the wound progress. From colonization, local infection occurs when bacteria or other microbes move deeper into the tissue and proliferate at the rate that invokes a response in the host cells. The infection spreads when organism invades surrounding tissue that if become uncontrolled, then it will become a systemic infection. These stages require intervention including systemic and topical antimicrobial therapy. Therefore, it is important for us to understand this model. Local wound infection can be characterized into classic and secondary signs and symptoms. Classic signs and symptoms of local wound infection are such as surrounding erythema, warm to touch, edematous, pain, and purulent discharge. While secondary signs and symptoms of local wound infection includes change in color of wound bed, absence or abnormal granulation tissue, malodorous, increased exudate, or increase in pain severity. M stands for moisture balance. George Winter in 1960 described that moist wound will accelerate healing by increased epithelialization rate, increased production of collagen, increased angiogenesis, autolytic debridement, and decreased pain. The image on your right shows comparison between wound that kept moist by covering and wound left uncovered to dry out itself. Next slide shows example of moist wound. Moist wound heals faster as epithelial cells move effortlessly across moist dermal surface, while in dry wound, the dermis dries out and forms cap that impedes epithelial cell migration. Pictures in these slides shows image of wound has high exudates with maceration. What is wound maceration? Wound maceration occurs when the area of skin surrounding a wound has an excessive amount of moisture in it. Although it is common, maceration can be dangerous, especially for the elderly. Wound maceration can harbor fungus and bacteria, increasing the likeliness of infection. Now we are looking at pictures of dry wound. Look how does it differs with the moist wound I have discussed in the previous slide. E stands for age of wound. This can be described as advancing or non-advancing age by comparing the measurement of similar wound from previous review. Non-advancing age is due to non-migrating keratinocyte. Advancing of age can be assessed by measuring the depth, length, and width of the wound. Advancing ages are pink and it shows healing is taking place, while non-advancing ages are raised, roll, red, or dusky. Next, we have to assess the surrounding skin for the following. Is there any redness, swelling, or any evidence of macerated skin changes? There is a difference between tunneling and undermining wound edges. Undermining occurs when the tissue under the wound edges becomes eroded, resulting in a pocket beneath the skin at the wound's edge. Whereas in tunneling, wound has a tracts that extend from skin surface to various subcutaneous tissue in an irregular manner. Hope these images can give a better picture of understanding the difference between tunneling and undermining wound edges. Images in the next slide shows different type of wound edges. For example, maceration edges, dehydration, undermining, and roll edges. We need to assess age of the wound for its moisture level and record if there is any extent of undermining or tunneling. Then aim to establish the cause and correct the condition that will permit epithelial advancement. Peri-wound skin management is just as important as wound bed preparation in wound healing. The goal of peri-wound management is to maintain an optimal moist wound healing environment while preventing skin breakdown and infection. Skin is more vulnerable in patients with certain comorbidities and conditions. Peri-wound skin refers to the surrounding areas within 4 cm of wound edge. Example of peri-wound skin changes are maceration, excoriation, dry skin, hyperkeratosis, callus, and eczema. We need to identify and treat abnormal peri-wound complications as indicated using appropriate treatment measure. The components as per time recommendation should be thoroughly assessed to optimize the treatment. Depending on the clinical findings for each component, time recommends certain clinical action aimed at correcting the tissue and facilitating the healing. For example, if non-viable tissue is present, then wound debridement is required to clear away dead or necrotic tissue. If there is an evidence of infection during assessment, we need to identify what type of organism involved. Is it a bacteria or fungus? Then we want to treat accordingly with the right local treatment with or without systemic medication. Maintaining moisture balance in the wound is very important. Assess the wound, whether it is a moist or dry wound. If the wound is too dry, we need to add on moisture. If it is too moist, then we want to control it and decrease excess moisture and exudate. Don't forget to assess peri-wound skin condition as well. Last but not least, it is crucial for us to determine whether the wound edges are undermined or not so that we can select the ideal procedure to get the wound healed. For example, venous leg ulcers generally have gentle sloping edges, while arterial ulcers often appears well demarcated and punched out. Rolled or everted edges should raise a suspicion of malignancy. Therefore, a biopsy should be taken for any suspicious wound. Let us move on to wound documentation. The aims of wound documentation are as follows: to record the history, to identify etiology factors, to detect is there any intrinsic and or extrinsic factors that may affect the wound healing, to obtain a baseline assessment for further comparison, to provide a legal record, and to use in evaluation and planning of wound management, and most importantly, to monitor wound progress. It is an effective communication tool available. During first visit, we should document all our findings using this wound assessment form as shown in this slide. Next, the wound assessment is followed by wound management plan, which we can document in this form as shown in this slide. Remember, one form for each wound. Wound progress form should be filled in every subsequent wound dressing. The findings of wound assessment and the dressing solution and material should be documented properly. All these documents are medical legal documents. Therefore, it is important to make sure that our handwriting eligible to read, and don't forget to sign and use your name chalk. All these documents should be kept in a safer place and for a proper record keeping. As we come to the end, these are the take-home messages for today's presentation. There are 3 most important points to remember. Wound assessment includes general and local assessment. Use time principle for wound assessment, and wound documentation is a medical legal document. These are my acknowledgement and references for this presentation. Hope you enjoyed my lectures. Thank you.